What I'd like to talk briefly about are some of the changes that we have made to the standard operating procedure over time. And this is basically a consensus document where the users or the regular users of the electrochemotherapy have come together and decided that certain things should change or certain parts of the original user document do not apply. And it's just to share some of these with you. So you've already seen this picture flashed up before. This is the original paper that was written in 2006. And it was essentially the guidebook. It's the user's guide. So anyone who wants to take up electrochemotherapy just needs to download this paper, and it tells you exactly what to do, what dose, where to put the patient, what anesthetic to give them, when to send them home. It literally does tell you what to do. But this initial user guide was based very much on the laboratory work that was done early on. So some of it is outdated. And with the test of time, we've been able to make some changes to this guide. As I said, this was originally done some 10 years ago, and we are still in the process of updating it. So we hope to be able to have a new user's guide within the next 6 to 12 months, if I'm being optimistic. So what are the obvious changes? Well, we started off with that machine on the left side of your screen, which was a little computer that had to sit on a desktop. You needed a medical student to man the pedals. Now we have an all-singing, all-dancing platform, as we call it, where you can input all the data. It's nice and it's colourful, and it, the computer sits on its own stand. It's very important that nobody unplugs it halfway through the treatment, because then you've got to start inputting the data all over from scratch. But the great thing about it is that all your data is stored there, and it can then be uploaded for data collection purposes at a later point. There also have been a few changes to the machines along the way. So there are now more features, such as features that allow you to treat patients who have pacemakers and implantable devices. This was us on our very first session with electrochemotherapy, and everybody who was everybody had some sort of excuse to be in the theatre that day. And the good news is it doesn't actually take this number of people to do the treatment. You probably do still need your trusty medical student to man the pedals, although you could do that yourself. And you need a scrub nurse, but actually it's not a sterile procedure unless you are carrying out a surgical procedure. So you just have to make sure that you have chemotherapy safe gloves and that you are protected from any potential spills from the patients. Now, some of the oncologists will do this in an outpatient sort of setting, but we do all of our electrochemotherapy in theatres because it's much easier. That's where the machines live. And if we need to do anything surgical, it's done all at the same time. So some other changes. We used to give Bleomycin as a whoosh. And obviously the impact of that is that you have high peak doses of Bleomycin within the blood, which means that there's an increased risk of lung toxicity. And so what we've started to do now is we recommend that you give it as a slow whoosh rather than a fast whoosh. So over a period of, 7 to 10 minutes, which means that you don't get that high peak, which increases your risk of lung toxicity. You will find that you will have many patients with large tumours. The optimal size for the best response to electrochemotherapy of a tumour is 3 centimetres. And that's because you can, with a tumour that's 3 centimetres, get round all of it with your probe. For anything that's bigger than 3 centimetres, you're unlikely to cover the surface area of that tumour or the depth of it. And therefore we recommend that, if you cannot debulk it, or you cannot treat the whole tumour, that you're probably going to need multiple treatments. We also have patients who are covered in hundreds of nodules. And with the older machines, you would have to wait for the machine to reload or recharge between every application, which meant that there was a time limit to how many of these nodules you could treat. So ultimately, you would have patients coming back for repeat treatments, either to the same areas or to other areas. And because of the risks of Bleomycin-related lung fibrosis, we recommend 3 to 4 treatments before you start to get really, really concerned. And certainly in our department, once patients have had 3 treatments, they then all have to have their lung diffusion studies done, and their renal function is checked at every visit. But certainly we don't start doing lung diffusion studies until we get to the 3rd or the 4th treatment. Obviously, if a patient has medical comorbidities, so COPD, emphysema, any lung condition that meant that they're not breathing optimally, then we would do these studies earlier if they were required. The other thing that's changed, and again this is anecdotal based on lots of people doing electrochemotherapy, is we used to have a treatment window of approximately 28 minutes. And what tends to happen on the machine is that your treatment window is green, the timer counts up, and when you get to 25, 27 minutes, it starts to go orange, then red, and at 28 minutes it would go red. And that would be the signal to stop. And what we found with patients who had hundreds of lesions is that you would get to 28 minutes and you'd think, well, I've given the bleomycin, what have I got to lose? And you would just keep going. And you would notice that those lesions responded just as well as the ones that were treated within that 28-minute window. And so the general feeling is that you could probably keep going for up to 40 minutes and it would still be effective. And we all tend to feel that, if you need to keep going, then you keep going. Your bleomycin's in. What's the worst that can happen? It won't be effective, but you've got nothing to lose by continuing your treatment. So this has an impact now for patients with lots of lesions or with lots of big lesions, because we're no longer restricted so much by the clock. At one point, we had to get 2 machines in to treat 1 patient. And I think that's becoming less and less of a necessity because of that increase in treatment windows. Okay. We are currently looking into the optimal dose for bleomycin. So a lot of the early work was done in the lab and a dose was chosen. And what we have noticed is that in certain cases, we have had to reduce the dose of bleomycin, either because of poor renal function or because of previous treatment with bleomycin, or because we're treating children, for example. And we've noticed that even with the reduction in the dose of bleomycin, the treatment is still effective. So we're currently looking at varying doses so that we can decide what the optimal dose should be. It may well actually be significantly lower than we have been using, which is great because then it means potentially we could treat our patients for more treatments. But if you have a patient who has poor renal function or pre-existing respiratory disease, you should consider reducing the dose of the bleomycin rather than just saying, no, you're not going to treat the patient, because it's likely to still be effective. When should you repeat your treatment of electrochemotherapy? Ideally, once you've given the treatment, you need at least 4 weeks to determine whether or not you've had a response. Now, this may be partial or complete. And it may be that you then want to go on and retreat that area if it has not responded. So you can wait at least 6 weeks. You need to have a window. This is not related to the risk of the bleomycin, because obviously that is there and that does not go away. But in terms of leaving enough of a window between treatments, a minimum of 4 weeks is recommended. Obviously, you want to be able to treat other lesions that you may not have treated the first time. So between the time you've treated the patient and they've come back for their follow-ups, they may have developed new lesions, and you may want to go back and treat those areas. But if you wait a little bit longer, you'll be able to tell whether or not your first treatment has worked, either completely or partially, and whether you need to retreat the same area. So it's just to bear in mind your treatment windows. We've already touched on coexisting therapies. And what we're tending to find is that a lot of our breast cancer patients have come from the oncologists. They're on lots of treatment regimes. They're having this chemotherapy or this hasn't worked, so they switch to something else. And what do we do about the treatments with bleomycin? Is there going to be an interaction? Will they work together or against you? It's difficult to know. And this is particularly important for our melanoma patients because there are lots of new treatments coming on all the time, and we don't really know what the interactions are between the drugs. So we don't ask that chemotherapy be stopped because obviously electrochemotherapy is palliative, and we don't want to stop a treatment, another treatment that potentially will have a benefit that electrochemotherapy cannot provide. What we do tend to do though is try and fit the electrochemotherapy between treatments. And ideally, if you have a week before electrochemotherapy and a week after, a week before chemotherapy and a week after, that seems to be a safe window for administering your treatment. But a patient being on another therapy does not stop us from offering electrochemotherapy. Obviously, the other risk is that the Bleomycin may sensitize the patient to the side effects of the chemo and vice versa, and that's something that we are very wary of. We've already had this discussion about electrochemotherapy and pacemakers, and generally speaking, it seems to be safe. So I have not personally caused anyone's pacemaker to fail. We've had one patient with an implantable device, and there have been no problems. Obviously, if you can, try to avoid placing your electrodes directly above the pacemaker where possible. And if in doubt, you have the pacemaker checked perioperatively, so before treatment and again before they go home. The newer machines, so it depends on what generation ECT machines you have, but some of them will have an ECG synchronization mode, which means it makes it relatively safe for them to avoid triggering something like VF. You also have to check which generation of pacemaker your patient has, because the newer generations tend to be quite safe and the older generations are not. So again, having a pacemaker checked, if in doubt, have it checked and have somebody from the lab on standby in case there's a problem. Lung metastasis used to be considered a contraindication to electrochemotherapy. When you're dealing with a condition such as melanoma, lots of patients have low volume metastases which are completely asymptomatic. And therefore, we do not feel that this is an absolute contraindication to electrochemotherapy. And again, it all boils down to the lung function. And if in doubt, you would conduct your lung function tests before carrying out the treatment. For various tumors, so obviously the optimal size for treatment is 3 centimeters. And if you have something larger than 3 centimeters, then it's perfectly acceptable to debulk the tumor and then to apply your applications to the base. People always worry about making things bleed. And one of the benefits of electrochemotherapy is that it does cause this vascular lock, this vasoconstriction in the treated area. You see the skin go white, and we often use it with wild abandon to things that are bleeding because it will stop them bleeding. Worst case scenario, you get your diathermy out and you stop the bleeding. Obviously, everyone is quite wary about the adverse effects of the treatment. It seems to be fairly well tolerated. You will have patients who will sail through it, no symptoms whatsoever. They'll tell you they had no pain. We tend to find that those who have the most pain tend to be the breast cancer patients, chest wall, who've had previous irradiation. They are the stereotypical patients who tend to have a lot of pain. But generally speaking, it's well tolerated. 688 patients treated so far. This is data recorded by INSPEC. You have to bear in mind that there are obviously centers who carry out electrochemotherapy who do not upload their data to INSPEC, so that number is obviously significantly larger. But the side effects that we tend to expect and prepare for will be infection, scarring, hyperpigmentation, pain, and ulceration. These are what the patients are warned about. They also have a consult with the oncologists, and we go to great lengths to discuss the rare side effects, the Bleomycin-related lung problem, because We've had one death from toxic shock. And when I say we, I don't mean St. George's Hospital on its own, but this is data from INSPECT and from INSPECT members. There's been one post-ECT death related to toxic shock syndrome. There's one bleomycin lung fibrosis related to ECT, partially responded to steroids. The patient required oxygen until she succumbed to her disease. And then we've had one death from bleomycin lung fibrosis, which we think was possibly related to sensitization from vemurafimab, although we'll never be able to prove that. Patient was on their second treatment with electrochemotherapy and developed shortness of breath 4 to 5 days post-operatively, seen in A&E, low SATs, and treated in the intensive care units with high-dose oxygen, all the things that you're not meant to do, and treated as an ARDS type patient until somebody twigged that perhaps it wasn't, by which time it was too late and there was no response to the steroids. So with this in mind, it is a conversation we tend to have with the patients who come to the clinic. And they often don't want to hear it because they have come to hear about this wonderful treatment that will stop their fungating tumors from fungating for a short period of time. And they've tried everything else, it's failed. So the last thing they want to hear is that there is a potential treatment from which every now and again there might be a patient who dies from it. And we don't gloss over the risk of bleomycin-related lung fibrosis, and it's discussed both by us and by the oncologists, so that the patients are aware that there is a potential risk. I have to say that so far we have only had one problem in terms of the bleomycin-related lung fibrosis, but it's something that we always bear in mind, and it's one of the reasons that you would consider doing a local an intratumoral injection rather than an intravenous injection with bleomycin. So those are most of the changes that we are instituting. No doubt there will be more changes as time goes along, as new drugs are and newer machines come into the market, and as more users start carrying out electrochemotherapy, there will be more things that will need changing.